Welcome to The Point. I'm Mindy Todd. Statistics vary slightly, but it's believed that 15 to 20% of known pregnancies end in miscarriage, the spontaneous early loss of a pregnancy. The actual number of miscarriages is likely higher because many happen before a person even realizes they're pregnant. Individuals who lose a pregnancy, even an unintentional one, can suffer a huge loss, as can their partners. They might wonder what they did to cause the miscarriage, or if they'll ever be able to carry a baby to term. Often they grapple with these emotions silently, not sharing their grief and loss with family and friends. Today, our topic is miscarriage, what we know and don't know about the causes, and how we can support those who've experienced the loss. With us is Shannon Uchkunis. She's the founder of Cape Cod Baby and offers supports to families through pregnancy, childbirth, and beyond. She also offers bereavement supports. Welcome back. Good to see you.
Thank you for having me back, Mindy.
And Erin Horahan is a therapist who works with individuals struggling with bereavement and major mental illness in private practice in Kingston. Good to see you again as well.
Thank you.
And Dr. Anisha David, she's an OBGYN physician practicing in Falmouth. Good morning and welcome to you.
Good morning. It's great to be here.
So Erin and Shannon were here earlier in the year and we discussed stillbirth. So Anisha, how do the terms stillbirth, miscarriage, or early pregnancy loss differ? Are we all talking about the same thing?
Yeah, so that's a good question. So early pregnancy loss we usually use to refer to pregnancies that miscarry in the first trimester. So usually from when a pregnancy is identified up to about 13 weeks after their last menstrual period. So that includes all the terms that you sometimes hear, like having a blighted ovum or a spontaneous abortion or an empty gestational sac. So those are all those pregnancies that we find that have an embryo without a heartbeat in the beginning of a pregnancy. We also kind of distinguish pregnancies between 13 weeks and 20 weeks as kind of a early second trimester pregnancy loss. And then usually we refer to pregnancies after 20 weeks that have a loss as stillbirth or fetal death.
As I just mentioned, the statistics on miscarriage vary. How common is it?
So unfortunately, it's very common. So the estimate is that early pregnancy loss can occur as often as 31%. A lot of those pregnancies are not always clinically recognized at first. So sometimes a person has their period a little late and they don't realize that they were pregnant. And so from the number of people who have a pregnancy that they identified that they knew that they were pregnant and who miscarry in the beginning of a pregnancy, that incidence is closer to 10 to 15%.
So what do we know about why miscarriages happen?
So there's a number of reasons why miscarriages can happen. Early pregnancy loss usually follows something being wrong with the chromosomes of a pregnancy. So that's present in up to about 70% of losses before 20 weeks. So nowadays we're able to find that through genetic testing, and usually a pregnancy at that that has an abnormal set of chromosomes, something does not develop correctly with the baby's heart or their whole nervous system, and so pregnancies fail early because of that. There's a number of other reasons that pregnancy losses can happen. There can be sometimes anomalies with the maternal uterus. So sometimes pregnancies implant incorrectly. So problems with inside the uterus being polyps or fibroids, kind of adhesions or septums in the uterus. Sometimes pregnancies can become lost after trauma.
So there's a whole host of reasons that could lead to this. Yeah. Mm-hmm. If a person experiences a miscarriage, are they more likely to have another one? I mean, we hear stories of some women who have 3, 4, 5.
Yeah, unfortunately. So after having one miscarriage, so typically the rate of miscarriage we say is around 15% in the general population, and after a history one prior miscarriage, we still say it's about 15%. However, after that, after 2 or 3 prior miscarriages, the rates go up a lot. So after 2 miscarriages, it's closer to 26%, and after 3, it's about 28%.
I see Erin and Shannon both nodding their heads at just about everything you're saying.
But you could also have one miscarriage and then go on to have perfectly healthy pregnancies following that.
Yeah.
Mm-hmm. So it's really, there's no definitive answer to that question.
Yeah.
It's different for everybody.
And we're talking about all these different reasons that could lead to miscarriage. So what puts a person at a higher risk for a miscarriage?
So the biggest risk factor tends to be age, extremes of age. So women who are really young, that has a higher rate of miscarriage, but more often we see women who are older who have more miscarriages. So the highest risk is for women who are over 45. The risk can go up to about 57%, which is really high. But after 35 is when the risk starts to go up. So for a typical low risk woman from the ages of 20 to 34, we usually say the risk of a miscarriage is about 11%, and after 35 it goes up to 17. So it starts to increase from there.
We say we're using the pronoun they in this conversation as much as possible because we should note that transgendered men can also get pregnant and miscarry. So, Nisha, can you explain how a transgendered man can become pregnant? So trans men realistically get pregnant the same way cis women get pregnant. So trans men, right? For just to back up and talk about terminology, are people who identify as male, use male pronouns, and they usually are born as the female sex, and at some point have transitioned to becoming male. And so a lot of trans men still have the same internal organs that women have. So they have a uterus and ovaries, and so the technical part of getting pregnant is the same way. Mm-hmm. So that can be through spontaneous conception, through intercourse, or through assisted reproductive technology. So if they're taking testosterone, can they continue to do so while they're trying to get pregnant or while they're pregnant?
So pregnancies can happen while people are on testosterone, but we usually recommend once we recognize that there's a pregnancy that you discontinue testosterone for the duration of the pregnancy because we don't want it to interfere at all with the development of the fetus.
Yeah. And then are individuals who use in vitro fertilization at a higher risk for miscarriage? What are the chances there?
Yeah, slightly. So people who have an IVF pregnancy, a 2003 study quoted about a 22% risk of miscarriage as compared to about 15 to 20% risk for those without.
Mm-hmm. Just like people experience childbirth differently and menstruate differently, there are also differences in what they experience physically when they're having a miscarriage, right? And so describe some of the more common physical experiences. And maybe, Shannon, you have a lot of experiences. Maybe.
So many times it feels like menstrual cramping, and it can be a little bit more extreme, or you can have back pain. I know for a lot of women, that's lower back pain is one of the symptoms, and of course, bleeding. And I know Erin can personally speak on.
Yep. So I unfortunately have had 4 miscarriages, and that started in 2008. And all of the symptoms that you're describing are exactly what I was experiencing. However, and not being initially educated on what was possibly going on for me, I, of course, just thought maybe it was just a heavy period or whatnot, but quickly going into the hospital after realizing this has, become worse, we got the news that I was pregnant, and that was the first miscarriage. Subsequent miscarriages, of course, being more educated and getting more care, unfortunately, I realized, that this was a continuous process, and which led my husband and I to decide to move forward with IVF, so in vitro fertilization. And we were very lucky to have 1 round of IVF. And but yeah, the process in and of itself can range. And I think that you just never know what journey you're going to head onto until you're in the middle of it yourself.
Yeah. Does that sound typical to what you see in your patients?
Yeah, I think there's a wide range of what things people present with. Sometimes we find out that people have a miscarriage on just routine screening. So they come in for a routine prenatal visit, and we look for the heart rate and we can't find it. Or they go for an ultrasound and there's not a fetal heart rate then. Sometimes people do have bleeding or cramping. A lot of times people also come in saying that their pregnancy symptoms that they had start to decrease. So symptoms like breast tenderness, nausea, vomiting, all of those things start to decrease, and so that prompts their concern.
Is medical intervention necessary during or after a miscarriage? And if so, what are some of the reasons there?
Sometimes the fetal tissue doesn't completely leave the uterus. And so you don't want to risk infection. Mm-hmm. So they'll have you come in to do a D&C. Many women I know, if it's after about 12 or 13 weeks, they don't want to do that because they know the form of the baby is there. That is their baby. Mm-hmm. And so they decide to try to go naturally and let things happen on their own. And that doesn't always happen for everyone.
And sometimes, and maybe you can speak to this, Nisha, sometimes, you're telling a patient that you're going to miscarry, and it's not like it just happens, right? It could be even a week later, or weeks, right?
Yeah. So there's a couple of ways when a person has a miscarriage identified that we can manage it. Some people need some time to process, and so they prefer to wait. And so you can expectantly manage people and wait for the pregnancy to pass, but that can take up to 2 weeks, sometimes longer, and then we have to intervene. You asked, two of the reasons why we really definitely need to medically intervene is when people have really heavy bleeding, or sometimes if they have signs of infection, because those could be life-threatening. Otherwise, there's a couple of options. You can wait for someone to spontaneously pass the pregnancy. You can give the medication to help expedite the contractions that help pass the pregnancy tissue, or the other option is to do a procedure like a D&C, like you were referring.
We got an email from a woman who had 3 miscarriages, and she wrote the 3rd miscarriage required a D&C, which made it all the more real than the first 2. Do you hear from people that when medical intervention is necessary after a miscarriage, it's more difficult emotionally?
I would say yes, because they're going through also a secondary physical experience with it. So it's not just passing a baby. It is going into the hospital. They're, dilating your cervix. They're scraping the lining of your uterus to get that done. Then you have additional pain from that. Mm-hmm. And sometimes you're required to stay in the hospital depending on the circumstances. Right. Of what you're going through.
Yeah. And we were talking about statistics earlier, and before we went on the air, Shannon, you were mentioning that sometimes women don't report it at all, especially if it's very early, right?
Correct, because sometimes, like Erin was saying, you don't know that you're pregnant, and you might not understand that you're having a miscarriage. So unless you go to the hospital and they check you for your HCG levels to let you know that, you are in fact pregnant, you are miscarrying. Yeah. You may just think your menstrual period is off.
Right.
Or extra heavy. Women trying to conceive, I know a lot, go through that.
Mm-hmm. Yeah. Go ahead.
And I can also just say that, speaking to what Dr. David just mentioned too about, just the series of events that can occur. I know for myself, I can speak to, the fear of not knowing what to expect and not knowing what next steps are best suited for me physically. And then also thinking, I am pregnant, this is a baby, and I am losing this baby. And so what do I do in order to honor this child during this process? Because this is not a viable pregnancy. But at the same time, how do we acknowledge that? But also, you have to, of course, think of yourself physically. And I think as a mother, you don't put yourself first, but I think your providers are obviously keeping you in the forefront of this at all times. And that's really hard to grapple with.
Yeah. Yeah, emotionally for sure. 866-999-4626 is our number if you'd like to join our conversation this morning. That's 866-999-4626. Our email address is thepoint@capeandislands.org, and we'll talk more after a quick break. You're listening to The Point. We are talking about miscarriages this morning with Shannon Uchkunis. She's the founder of Cape Cod Baby and offers supports to families through pregnancy, childbirth, and beyond. She also offers bereavement supports. Erin Horahan is a therapist who works with individuals struggling with bereavement and major mental illness in private practice in Kingston. And Dr. Nisha David, an OBGYN here in Falmouth. 866-999-4626 is our number if you'd like to join our conversation. That's 866-999-4626. Our email address is thepoint@capeandislands.org. I don't know if we know the answer to this, but is miscarriage more or less common than it was 30 or 40 years ago? Are our rates about the same? Do we know the answer?
I think the rates are about the same, but as we were talking about earlier, many people didn't report it or didn't know what was happening. So I think it's kind of skewed when you look at it.
Yeah. Could increases in any rates be attributed to the over-the-counter pregnancy tests so that people know they're pregnant early? I mean, remember that we didn't have that.
Yeah, I agree. I think people find out that they're pregnant earlier than they might have in the past. You can do home pregnancy tests that probably weren't available 30, 40 years ago. I think that there's been a slight increase in miscarriages reported since the 70s, but when you account for how early we recognize a pregnancy now, also women are delaying pregnancy till later in their life, right? So nowadays women are working, they're pursuing a career, and they're generally older than they used to be when we started families. So now, unfortunately, that does raise the risk of miscarriages for older women.
So many people spend years making sure they don't get pregnant for some of those reasons you just said, only to find out that later that they have difficulty getting pregnant or can carry a pregnancy to term. How does this contribute to the emotional roller coaster of pregnancy and loss? Anybody?
I know for me, I thought that I was younger. And then when we began IVF, I was considered geriatric.
How old were you?
I was in my early 30s. And I thought, I'm geriatric? Okay. But yes, I think that is definitely something that, a lot of women are really considering nowadays, and but they are grappling with, like we said, their personal life and their career.
We have an email from Jennifer, says, thanks for the show. After 3 miscarriages, we still don't know why they happened. We did every sort of test and found out nothing. I finally got my baby and then another at age 42. To all mamas out there hoping and suffering, take heart. I give credit to acupuncture and homeopathy. I really didn't want to deal with the D&C procedure, but it was necessary all 3 times. Yeah. 866-999-4626. That's 866-999-4626. Or our email address, thepoint@capeandislands.org. So as with this email, we tried everything. We couldn't find out why this happened.
Yes.
And I'm imagining that's pretty common. We don't know why it happened. Sometimes you get a reason and sometimes you don't.
I know for me, my diagnosis was idiopathic. We did not know why. I was very healthy. I had no trauma history. There was nothing in particular that was being shown in the testing. There were no genetic abnormalities. It was just a real mystery. And so, like Jennifer, it was just really scary, but also frustrating. And really, it's just so aggravating.
Yeah.
It's hard, too, when you don't have an answer, because then you put all of the blame on yourself.
Yes.
Yeah.
And it's not your fault. There is nothing you could have done differently in most cases. But I feel like we take that on because we don't have any other answer.
Right. That sort of guilt, even though you shouldn't be feeling guilty,
Exactly.
many women will feel that. And even, for the rest of their lives, say, what could I have done?
Right.
You probably hear this from your patients, right? What did I do?
Yeah, that's one of the most common questions, right? So after anyone has a loss, regardless of the circumstances, people are always wondering, what did they do wrong? And unfortunately, it's out of your hands most of the time. I mean, like I was saying before, a lot of pregnancies fail because of genetic reasons, but some of them don't. Sometimes we know that there's a perfectly genetically healthy baby, and for whatever reason it stops growing. Sometimes we can do additional evaluation that helps us give a couple of possible reasons as to why that happens. So a lot of times we check different lab work, so your thyroid levels. Sometimes we check for people who have recurrent miscarriages, people's predisposition to forming blood clots. And so we look up perform these different tests, also check to see if genetically you're carrying any abnormal chromosome arrangements that could be passing on. And so we look for all of these reasons to hopefully find a reason that we can prevent for a future pregnancy.
Right.
And how do you, and this is a question for all of you, how do you, when you counsel someone who's gone through a miscarriage, maybe several miscarriages, when to try again? First, there's a physical answer to that, right? Emotional answer is different. What's the physical answer, Dr. David?
So the physical answer is our bodies are amazingly programmed to be able to reset themselves and be able to get pregnant again. So after a loss, usually within 6 weeks, people have a spontaneous period again. And realistically, you can get pregnant the very next cycle. the uterine lining sheds and regrows and everything's back to baseline. We usually recommend waiting at least a period or two. But after that, there's no, depending on how far along that last loss was, if it's an early first trimester loss, there's no increased risk of having a pregnancy shortly thereafter. For later pregnancy losses where the cervix had to dilate a lot, we recommend waiting longer, just because it does increase the risk of the cervix not being fully closed.
Okay, emotionally. That's an answer that's different for everybody, right?
Right.
Yeah.
You're going to have to decide when you are ready to try again. I know the majority of my clients feel they need to wait a certain amount of time. And typically they get pregnant within the year. Later losses, obviously, they wait longer. Because as Dr. David was saying, that's a whole nother ballgame for what you're dealing with in terms of physical, mental, emotional, trying to get back to where you feel healthiest.
I think there's also something to be said for couples who, after a miscarriage or a stillbirth or a loss, are told, sorry, you can't have another child. You probably shouldn't get pregnant again. And I think that's something to highlight too.
Wait, do people say that?
I think that medically speaking, and I'm sure we can talk about that, but sometimes people are told it's probably not in your best interest because of the results of how this pregnancy came about, or because of genetics or whatnot, that maybe it's not.
Oh, I see. When there's an actual physical reason,
and so
So I've had definitely patients come to me saying that other providers told them they can't get pregnant again, or that they shouldn't get pregnant again. Usually, though, there really is some way that if you wanted to, my belief is if you want to have a pregnancy, we should try everything we can to have that happen.
Yeah.
I'd like to note, too, that when you do have the loss and you're trying to rebuild and people knew that you were pregnant and now that you're not, they can tend to say things that can be hurtful. The majority of the time, they don't mean it. Right. So when you hear, don't worry, you can try again, or there must have been something wrong, the person who loses the baby and the couple who loses the baby, that's their baby. They wanted that baby.
Right.
And so people aren't meaning to be harmful, but sometimes they don't know the words to say. So if you just say, I'm here for you if you need to talk, or cook that family a meal, or offer to do the laundry for them, because they're trying to dig out of this devastation that they've suffered.
Yeah.
And they just need friends and family to be close and to be there.
Yeah. When a baby is born with all its fingers and toes, it's really a miracle. What many of us don't realize is that half of fertilized eggs don't end up as a viable pregnancy.
Yes, I know for myself in the IVF process, we had several, during our retrieval, we had several eggs that we thought were viable, but then of course did not meet the 8-cell division in time in order to make it, of an embryo.
So what do we know about the body's natural process of preventing development of an embryo that isn't viable, and what's still a mystery about that? I guess that's a question for you.
Yeah, that's a great question. There's probably a lot we still don't know. We know that cells that babies tend to not continue to grow when something's wrong. So unfortunately, early miscarriages, the reason why most miscarriages happen in those first 10 weeks or less is because those are not pregnancies that are going to be healthy pregnancies. So our body stops growing them. The cells don't continue to divide. A heartbeat never forms. And if each of those milestones of cell development and growth that turn into a baby don't happen, it stops. The whole process stops. And that's...
Yeah. So I'm sure we have some misconceptions or myths about what causes. So what do we know does not cause a miscarriage?
So those are good questions. I get a lot of that. So, a lot of people blame themselves for all sorts of things for why they have a miscarriage. Things that don't cause miscarriage. So history of prior abortions, that's a very common concern that people have. People often have a lot of guilt surrounding past times that they had a pregnancy that they terminated, and they're worried that because they made that decision, this is their punishment later. And that's really not the case at all. That does not raise your risk of a miscarriage. Other things people worry about, foods they've eaten or exercise that they've done, or did they not take prenatal vitamins or things like that. And, for prenatal vitamins, for example, I think that they're excellent, and folic acid has been shown to help increase cell development. And for early, there's some slight reduction of pregnancy loss with people who take folic acid. But overall, prenatal vitamins, most people in the U.S. get a balanced diet. We have enough nutrients to grow a baby. So there's a lot of blame that people put on themselves.
Yeah. We have an email that says, I had a live birth followed by 2 miscarriages. Both miscarriages happened almost immediately following 2 severe emotional trauma events. I was told there was no connection, but I've always felt that the trauma contributed to the miscarriages. Is there any evidence that they're connected?
Go ahead.
I think that sometimes, of course, we have psychosomatic symptoms that occur where our body and our brain, just are trying to figure out what just happened. And so, of course, physiologically speaking, it can cause an amount of stress that, of course, can impact the body. And so inadvertently, it will impact the pregnancy. But, of course, I don't think that there's enough research that talks about that. And I think that there should be because of this listener, I presume that would be so helpful. And I know me, clinically speaking, working with people who have had a series of trauma histories, and then, of course, had that psychosomatic, response. It's important to know. We're
really just starting to learn a lot about the impact of trauma, a lifetime, how trauma impacts our health across the board for the rest of our lives, right? So there, as you mentioned, there's certainly a lot of room for some research in this area.
Yeah. I think there's definitely data that shows that chronic long-term stress that causes an increase of our body's response to stress, so increased cortisol levels, can be adversely linked to pregnancy loss. So, that doesn't typically, there's no clear relation between people who have an acute stressful event, who have an acute illness in a loved one, or are busy with work or things like that, or an argument that day. But for people who have chronic stress, people who are in war zones or have continual insecurity financially or with food or things like that, those people do show that the studies show that they do have higher rates of miscarriage.
What's an ectopic pregnancy, and can a pregnancy be saved, and are some people at higher risk?
So ectopic pregnancies it's a pregnancy that's not located inside the uterus. So for a person to have a healthy pregnancy, it needs to be located inside the uterus. Sometimes pregnancies can implant in different places after fertilization. So they can implant in the tubes. They can implant more rarely on the ovaries or in the abdomen or in the cervix. And unfortunately, those pregnancies can't continue onto a healthy baby. There's no way. I know a lot of people ask me, well, can't we move it? And unfortunately, we can't. That on a cellular level, when that pregnancy implants, it grows into the tissue that it's attached to, and we can't move it. And unfortunately, when those pregnancies implant in other places, it puts the mother at a great risk of pregnancy, of bleeding, essentially. So the pregnancy grows into the wall of the fallopian tube, and that's a very vascular area that's not made to support a pregnancy. And so as it grows, it can cause that fallopian tube to rupture and cause heavy bleeding. And the same thing can happen in each location where it can implant. And that can be life-threatening for people.
And when those pregnancies happen, you still will get a positive pregnancy test.
That's right.
Unfortunately, you don't know that it's not the typical pregnancy when that happens.
So at what point do we discover that? I mean, you go to the drugstore, you can say, hey, I'm pregnant. And when do you discover that it's not in the right place?
Yeah, it's hard. So sometimes people show up with the same symptoms that we typically think of as a miscarriage. So that can be some bleeding or some cramping or some pain. Sometimes people are totally asymptomatic, and it's when we go for imaging that we notice it's not where it's supposed to be. We can look at that pregnancy hormone, and that number that we follow, that HCG level. If it's over a certain value, we expect to see the pregnancy inside the uterus. So when we don't see it over that value, we don't see something in the uterus, we know that unfortunately it's not healthy. It's not where it's supposed to be. And that's sometimes how we make the diagnosis.
Yeah, what a tough conversation to have with your patients. Yeah. So do you think healthcare professionals talk enough about the possibility of miscarriage with a woman, or has expressed that she'd like to have a baby? Do we talk about that?
Sometimes women don't want to hear those things because you expect when you're trying to conceive that you're going to be able to conceive naturally. You're going to have a healthy pregnancy and a healthy baby. I know in my line of work doing bereavement care, many couples don't want to hear anything about that, and that's perfectly fine.
Mm-hmm. I think you're right. Absolutely. I think this is supposed to be a happy, joyous time, and of course, the idea that this could not happen is definitely something that people don't put in the forefront of their thoughts when they're thinking that they're going to have a child. Mm. But I think for repeated miscarriages, of course, that fear and that conversation tends to pop up much faster. I know it did for me personally, and it also, of course, in my work with clients, it's a definite forefront thought.
Yeah. So how do you, Dr. David, counsel a person who's experienced 2 or 3 miscarriages on what they're, what are the options? What do you tell them?
Yeah, that's hard. So the first step would be doing some sort of an evaluation. We want to check for some of the known things that we can treat about pregnancy loss. So we would check blood work for the mom, looking for their hormone levels, like their thyroid levels, make sure those are in range. We're going to look for indications that they can form blood clots. So antiphospholipid antibodies syndrome, we look for the screening tests for that. We also do an evaluation of their uterus to make sure that there isn't like a polyp or a fibroid or a septum or something inside the uterus that's causing the pregnancy to not implant correctly. We also look at their chromosomes, so doing a karyotype of the mom and then also of the other parent, the second parent, to check and see if there's something that is causing them to have recurrent loss. We usually start with an evaluation, and sometimes we get an answer. Sometimes there is a clotting disorder that we can then put people on anticoagulants, either aspirin or heparin or something like that, Lovenox, throughout their pregnancy that then prevents that miscarriage from happening again later. Sometimes we find a chromosomal abnormality, and so then we talk about other ways to conceive. So using a donor or doing IVF to pre-select an embryo that's genetically healthy. Those are all options. Sometimes there's something inside the uterus that we can correct. We can do a small surgery to remove a septum or to remove a polyp or fibroid that might be interfering with the implantation. Sometimes people need IVF, like we've talked about. Sometimes people need to use surrogates. There's a lot of options of what we can do.
866-999-4626 is our number. That's 866-999-4626. Our email address, thepoint@capeandislands.org. We'll talk more after break. You're listening to The Point. We are talking about miscarriages this morning with Shannon Uchkunis. She's the founder of Cape Cod Baby and offers supports to families through pregnancy, childbirth, and beyond. She also offers bereavement supports. Erin Horahan is a therapist who works with individuals struggling with bereavement and major mental illness in private practice in Kingston. And Dr. Nisha David is an OBGYN practicing here in Falmouth. 866-999-4626 is our number if you would like to join our conversation. That's 866-999-4626. Our email address is thepoint@capeandislands.org. So going through the loss of a miscarriage can be very lonely, which in a lot of ways is surprising when you consider how common it is, but it's not something most people talk about openly. So do you think misconceptions about miscarriage have resulted in this stigma being attached to those who have one? We talked about the guilt, I had a glass of wine, or maybe I'm overweight, or, there's all these things that you tell yourself. So talk about, and Erin, I'm going to ask you because you've been very open about your experience. It's a lonely, isolating place to be.
Yes, it's exciting, and then it's terrifying. And then I think you just, you're in this state of grief that you don't realize that you're in, because you oftentimes don't recognize maybe how excited you become as quickly as you do. And of course, then you have to, I know for me, my husband and I were both very much on the same page about how excited we were each time. Of course, with each subsequent loss, it just got harder and harder. But yeah, I think that it's very easy to fall into a real state of just fear and also just panic while this is happening. And then, of course, all of the feelings and thoughts that come along with it. The woulda, coulda, shoulda game is what I call it.
Yeah.
And that's a really awful game to play.
Yeah. And you see that a lot, Shannon.
I do. And many couples don't feel the same things because obviously
True.
the birthing person is the one that physically goes through the loss. And so sometimes the partners don't understand, why it's lasting so long. Why are you stuck in this, terrible place? And they feel like they've already moved on and they're ready to try again. So you really have to be a team, work together, talk, communication, and be very open with your feelings.
Right.
Well, I think we also forget too that the other partner, that's not going through the physical part of this is a big loss for them too. And I think sometimes we overlook that the pain that they're going through at the same time.
Where Erin works in Kingston, they actually have a group for
Yes.
the other partner, which I think is so amazing because it is so incredibly needed.
Yeah, my private practice is in Kingston, as you mentioned, at Hope Floats Healing and Wellness, which is a nonprofit working with people who are struggling with all forms of grief related to all different forms of loss. Shannon's talking about, in particular, our dad's group that we have, and it's just a wonderful addition to all the services that we have, and a lot of our grief services are free of charge as well. But yeah.
And what do you hear from the dad's group? I mean,
Well, I unfortunately, I don't get to help run that group. Ken Brack is the co-executive director of Hope Floats. He and his wife Denise started Hope Floats in memory of their son Michael, who passed away in a car accident. And so Ken helps co-facilitate that dad's group. And I think that it's a real sacred spot for fathers who don't often get a lot of time to talk about their feelings and thoughts about what has happened. And so it's a myriad of conversation, I'm sure, but I know it's very lively, and I know that it's very supportive.
What about same-sex couples? Is there support for them?
And so, no, not right now. And that's definitely something. It's interesting you say that because it's on the agenda, if you will. And so we're really wanting to expand all of the services that we have, but we need volunteers to do that. And and of course, funds are also always at a premium.
And I think, as Erin was saying, that Ken is the one who runs the group for the men. I think that's really important because they feel more comfortable seeing that other men can feel these feelings, and it's okay. And no matter what the loss is or how they came to be in that group, that it's okay to show your feelings. It's okay to share your story and work through things together.
I think, and also just, just having like-minded people together, and just recognizing that you're not alone, and that, a loss is a loss is a loss, no matter what stage you're in.
Yeah. Miscarriages, even if it's, as we were saying early, 6-8 weeks into pregnancy, is devastating for many people. And people might be less inclined to share the news because they've not told others that they were even pregnant yet. For people who've never had a miscarriage, it might be hard to understand. It's so early, right? And as you were saying, Shannon, people, they say things they don't mean to be mean, but they're saying, well, yeah, you can try again. And so, what are some of the things we need to keep in mind when we learn that we have a friend or a family member who has gone through this process? You mentioned just, hey, I'm here, I'm sorry, and I'm here to listen. But I guess the big thing is be careful what we say.
Be
right?
gentle with them.
Yeah.
They're in a very, I don't even know how to explain the space that you're in at that time.
Yeah.
But you have to be gentle.
Sensitivity is of the utmost importance. And I think sometimes we feel compelled to have to say something, and actually there are no words. there really are no words for what's going on with that person and what they are feeling and thinking. And so, like I've said before, sometimes it's just important to just be present, and that you don't really have to say anything. Just show up and express your love in ways that you feel most comfortable.
Yeah.
I think sometimes people, you hear that someone else has had a loss, and the feedback I get a lot is that others, when they hear this, are tempted to either console in a way, and sometimes that kind of that makes it harder for the person who's having the loss to feel what they're feeling. So sometimes people will say, "Oh, it's okay. You're going to have another pregnancy," and they might not be aware that a person's had repeated miscarriages, that their chance of more miscarriages is increased. Sometimes people give their own story, and they'll say, "Oh, I've had a loss too. I understand," and not every loss for each person. No one feels the same thing the same way. So I think it's important to know that it's helpful to tell people that you're there for them, but I think sometimes we project onto other people what they must be feeling, and I think that's probably the most helpful thing, is to try to be cautious not to do that.
And I would imagine you get varied responses when you tell a couple, that it's been a miscarriage, or whatever news you have that's starts that grieving process. It's such a shock. I imagine that sometimes sitting across from you, they're probably at this point haven't absorbed that yet. They're just trying to take this all in and trying to keep composed, if you will, right? And then others who will break down right in front of you, right?
Yeah, that's entirely true. I think in my job, we thankfully see the best of times and unfortunately the worst of times too for people. So when people have bad news that their pregnancy isn't healthy, you get a wide range of emotions. People who need time to process, they want you to reconfirm that it's in fact a loss. They just need time you could tell them all of the options of how to help manage a pregnancy loss, but they're not going to hear any of it.
Yeah, I was going to say
it's in one ear out the other for a moment. So I usually have people kind of take some time to process it, and then for each person, how they move forward is different. Some people are like, they want to do everything medically that they can to quickly move forward, and so they want a procedure to help pass the pregnancy and move on. Some people want to take the time to feel to kind of wrap their head around it first.
Yeah.
Every family that I've ever worked with, I know that they always ask for another ultrasound when they're in the hospital before anything starts, because you do hold out that hope that maybe that first ultrasound was not correct, and we're going to just check to make sure.
Yeah. And talk a little bit about that same thing, the processing. That's different for everybody, right? And when you work with somebody who's had a couple of miscarriages, what are those conversations like when you find out they're pregnant again?
Again, it's different for everybody. Typically, they're very cautious about who they tell, the steps that they take, what they're doing, and generally they play the game of what if. So they'll cut out all caffeine. They won't drink any alcohol. They'll stop sexual activity. They're trying to hold on to this pregnancy because there are so many unknowns of why it happened last time or the last 3 times.
Right. I know for me, Jennifer in the email, she talked about acupuncture and other, wellness modalities. I know for myself, I did everything. I drank the kale. I did the acupuncture. I did everything that I possibly could because I knew that I didn't want to have regrets, but at the same time, this was not in my control. And so what I could control were these ideas that supposedly could help in any way. And that I knew made me feel a little better. It didn't remove the pain, but in hindsight, I felt at least I did what I could.
Yeah. Is there a taboo about talking about miscarriage in the workplace, sharing that information with coworkers or a boss? What are your thoughts on that?
I think many people are very uncomfortable with the topic. And so people who experience it, who want to talk about it, who want to feel it's okay, I can share my experience and still feel accepted, it's difficult.
Yeah,
for them.
absolutely. Especially considering it being such an early process. It's just very private. And I think, once again, as we've said before, it makes it hard because a lot of people don't recognize it as, a child or as a true pregnancy per se.
Yeah. And so those, we talked about it before we went on the air, the dates, and this, I guess this kind of goes, we don't know why somebody's having a bad day, and there could be many reasons, but it might be, Erin, for you, the date of one of those losses, and you're feeling it that day. And so again, just kind of being in, and we're not going to know that. I'm not, if I'm working with you, I'm not going to know that that's why you're down today.
That's right. That's right. It's very personal, and I don't forget the dates. And I feel like it's a way to honor and memorialize my children, and that's how I look at it. But a lot of people I know don't look at it like that.
Yeah.
And many women can have triggers too that you don't know are going to set you off if you see somebody else at work who is pregnant or just had a newborn, or a certain date comes up, or you hear a name that was one of the names you had on the list for your child. Those things can trigger you. And so if you're at work and you start to break down and people don't know at work that you've been through this, that's difficult as well.
Yeah.
Right.
What are your thoughts about, Erin talked about honoring the children that she lost. Is that pretty common practice?
Absolutely, it is. I work with a company that's run by a woman named Alicia Neal, and she has a nonprofit that's called Angel Babies. And once a month, we get together and people donate formal gowns, and we make little memorial gowns for the babies. They can be for babies that are 1 pound all the way to a newborn baby. I've been part of several baptisms in the hospitals, and the babies get to wear these gowns because the parents want all of these things for their children. And so these are small ways that they get to be able to have those special moments that they were expecting.
Right. Now, we've talked a little about, Shannon, what you're doing. We've talked about, Erin, with your organization, Hope Floats Wellness. What do you advise patients, Dr. David, when they have a miscarriage? Do you suggest, here are some information on support groups, and what direction do you send them?
I think it's helpful to find comfort from both your family and your friends, but I think also formal help helps, so I think local organizations, and that varies from place to place what's available, but I think there usually is a number of community resources that we can point people in the direction of. So I think in our office, we keep a list of either support groups or counselors that that have specific background in this, that this is their focus, so that we can, I think it's helpful for people to talk to someone. Yeah.
Also, Erin, we're so sorry and sad to hear about the miscarriages and the loss, but you have a 3-year-old little girl too. So I guess we have about 30 seconds left. Mm-hmm. So what's your advice to women who have been going through the same experience you have?
I think if for us, I don't like being told no, and so being so stubborn, I just said I want to have a physical child, and I have 6 angel babies, as I like to say. However, I wanted a physical child here, and so I said we deserve to try. And I think if you feel like in your heart that you deserve that and you want that, then
go for it.
Go for it.
All right. Shannon Uchkunis, Erin Horhan, and Dr. Nisha David, thank you all for coming in. And Erin, thank you for always being so open about your experience.
You're welcome.
I think it's really helpful. Thanks so much.
Thank you.
I'm Indy Todd. Thanks for listening.